Can we start this session?
Sure.
Good afternoon, everyone. Welcome to weekly MODY and LADA. Speaker for today is Dr. Dr. Chew Ken Seng, endocrinologist from Hospital Sultan Ismail Johor Bahru, and our chairperson is Dr. Gayatri Devi, consultant endocrinologist from HKL. Doctor, little bit about the from University of Malaya in 2010 and completed the MRCP UK in 2015. She completed her subspecialty training in endocrinology in the year 2021 under Ministry of Health Malaysia and currently working as an endocrinologist in Kuala Lumpur. She has vast experience in clinical research and publication of journals related to endocrinology. Without further ado, let's welcome Dr. Gayatri to chair this session.
Hi, thank you, Priscilla. Thank you for that kind introduction. And I'm here to introduce our speaker for today. Our speaker is Dr. Chew Ken Seng. And he was here today to tell us about the less popular forms of diabetes like MODY, type 1 diabetes, and LADA. Dr. Chew is a colleague and a friend who is currently practicing as an endocrinologist in Hospital Sultan Ismail JB. He graduated from IMU in 2012 with the highest honors, really, and went on to complete his MRCP in 2017. He also completed his special certificate in endocrinology and diabetes UK in 2022. So Dr. Chew completed his fellowship in endocrinology in Malaysia in 2023. He's a keen researcher as well. He's published in multiple international journals. He has also been active throughout his years in training and organizing quite a few endocrinology and diabetes workshops, updates, and seminars, both by KKM and University of Malaya. So without further ado, let me pass this virtual stage to Dr. Chew.
Thank you so much for the kind introduction. Nice to meet you again, Gayatri, despite virtually. Okay, so without wasting much time, I'll just begin. So I given the task to talk about type 1, the MOD, as well as LADA. So like what Gayatri mentioned, these are the less, common forms of diabetes. So really, before we begin, let's just discuss about one of the cases that I've seen recently here in JB. So I'll give you a case. She's actually a 17-year-old lady who was diagnosed with diabetes in 2019. At that time, she was 12 years old. She presented acutely with DKA and was started on insulin since then and never stopped. However, unfortunately, her control wasn't very good. She had another admission for DKA in 2022. And from the records, despite being on KK follow-up, but we managed to trace back some old HbA1c. Apparently, it's not very good, very bad actually, to be honest, ranging between 15 to 17%. And she was on very high doses of acrapid and insulatard. Mind you, she's just a very small-sized lady, a young teenager, and she was not very compliant due to hypoglycemia. And I first saw her back in just a few months back in March this year, whereby she was admitted for a third admission for DKA due to CAP. She presented dyspnea and vomiting, and the blood parameters were very consistent with DKA. So in terms of target organ damage, there was none. In terms of weight, she's currently 60 kilos with a normal BMI of 21. However, from the records, her heaviest weight was 56 kilos. And, I did not have a height, but assuming, the average height of 140 cm for a 12-year-old girl, she was probably a little bit overweight at that time, with BMI of 28.6. In terms of family history, her maternal grandfather and paternal grandmother has diabetes, diagnosed in her 50s. However, she does not have any first-degree relatives that have diabetes. So her parents and siblings do not have diabetes. And of course, she does not have any autoimmune conditions. So subsequently, she had 2 sets of DM and auto antibody stamps. As you can see here, back in 2019 and later on in 2020, they're actually negative for anti-GAD islet cells as well as also IA2. And then she has 2 readings of low C-peptide, 187 and 85.5, but we don't have any RBS during those C-peptide readings. But I think most importantly, I want to point out is these 2 readings of C-peptide were taken during her admission for DKA, during her first presentation of DKA in 2019, and of course, during this admission in March 2024. So in summary, she's actually a young onset diabetes at 12 years old, probably a little bit overweight, but actually no other features of metabolic syndrome. She wasn't hypertensive, there was no dyslipidemia. She was on insulin since diagnosis and had 3 admissions for DKA. Her antibodies were negative twice, and C-peptide were low, by it being taken during DKA. So what do you think? Do you think this is a case of a type 1 diabetes, but since antibody negative, do we want to consider a type 1B diabetes, a type 2 diabetes, LADA or MODY? So, so what our physicians thought it was during these many years of treatment, we thought it is a case of a type 1B diabetes. Also, we thought. All right, so let's move on to the discussion. So today, we're giving you the topics of LADA, MODY, and type 1 DM. It's actually quite broad. If I want to talk about each individual topics, it'd be quite difficult. So instead of just focusing on the management and so on, I think let's focus a little bit more on how to differentiate between these 3 types of uncommon forms of diabetes. And we are just out from the Olympics, so I'll teach you how to hit the right target. All right. So how to approach to a young onset diabetes, and the definition is heterogeneous, but generally we say the age of less than 35 years old. All right, so this is my outline. I'll talk a little bit of some definitions and proceed to talk about type 1 diabetes, LADA, MODY, how you would approach a case of a young onset diabetes, and then back to our case. So what is diabetes mellitus? It is a heterogeneous group of metabolic disorders or carbohydrate metabolism, and the end result is hyperglycemia. And you look this from the ADA guidelines, you can diagnose it using HbA1c, fasting blood glucose, 2-hour postprandial glucose, or if any patients who came in with DKA or HHS. And if the patient is not overtly symptomatic, you will need 2 abnormal blood results. And just to point out to you, in a Malaysian diagnosis for diabetes, we have a lower threshold of diabetes of 6.3% owing to our own local research. All right, so ADA classifies diabetes into 4 types. Type 1, type 2, third one will be other specific types of diabetes, or sometimes called atypical diabetes, and the 4th will be gestational diabetes. They place LADA as a subset of type 1 diabetes. However, 90% of diabetes are type 2, and 5 to 10% are type 1, and less commonly are the others. So this is the 4 different types of diabetes. You can see number 1 is type 1, number 2 is type 2, number 3 is all other types of diabetes. It can be MODY, it can be drug induced, it can be infections, and so on and so forth. And then the 4th will get gestational diabetes. So we're talking about these 2, the autoimmune, whereby it encompasses both type 1 and LADA. And then subsequently, we'll talk about a little bit on MODY, which is a monogenic diabetes. So the ADA classification, has been criticized to be incomplete. That's why there's another classification by WHO. So instead of the 4 types, they actually created 6 types, and they consider LADA as a separate form of diabetes. Yeah, so it's under here the hybrid forms of diabetes, or also called the slowly evolving immune-mediated diabetes of adults. And of course, they created another subset for unclassified diabetes for temporary classification if you have not decided what type of diabetes the patient is. So we are done with the classification. Let's talk about type 1 diabetes. Yeah. So the reason why I put this shooter over here is he reminds me of somebody with type 1 diabetes, in the sense that he's young. You see, he got so many gadgets, just like as if type 1 diabetes, you have the insulin pumps, you have the CGM. So yeah, I'll put him to represent type 1 diabetes. So these are some of the guidelines that you can refer back to, including that by the ADA and ASD, for which a lot of my presentation is actually based on this. We also have our own local guidelines in the management of type 1 diabetes in children and adults. So type 1 diabetes is definitely genetically related. However, unlike MODY, whereby you can blame just a single gene, it is not so straightforward in type 1 diabetes. But generally, we say it's related to the HLA region in chromosome 6, and it accounts for 30 to 50% of genetic risk of type 1 diabetes. So being predisposed to genetically to type 1 diabetes does not mean you will develop diabetes. As on the right hand side, you can see that islet autoimmunity risk is not actually the same as the risk of type 1 diabetes. There's actually some other external factor that trigger this islet autoimmunity to convert into a full-blown type 1 diabetes. And if you're interested in numbers, in monozygotic twins, not necessarily the monozygotic twin will develop diabetes, but the risk is as high as 1 in 2 to 1 in 3. In siblings, it's 1 to 4. In parents have type 1 diabetes, passing on to their children, and the risk is 1 in 5 for father and 1 in 40 for maternal. And in general population, it's 1 in 300. So as type 1 diabetes, you all probably already know, it is actually the autoimmune destruction of the pancreatic beta islet cells leading to severe endogenous insulin deficiency. So from this description itself, what's very important in diagnosis type 1 diabetes will be because it's autoimmune disruptions, you need to look for autoantibodies. And because we're talking about severe endogenous insulin deficiency, we need to measure C-peptide. The incidence of type 1 diabetes is variable. It is highest over here in the center. You can see in the Nordic countries, such as Finland, Sweden, and Norway. We have a little bit positive data in our own, local data. However, you can see it's probably similar to that in Asia in the light blue, with the incidence rates of about maybe 5 to 10 per 100,000. So the thing about type 1 diabetes is, let's say you're at the age of less than 10 years old, it's almost always going to be type 1 diabetes. So on the left-hand side, you can see these two bar graphs. However, as you get older, because of the increasing incidence of other more common forms of diabetes, namely type 2 diabetes, you start seeing the percentage of percentage of diabetes caused by type 1 starts to be lower. At the age of 10 to 14, 90% are type 1 diabetes. In 15 to 19, 80% are type 1 diabetes. And below the age of 20 years old, you can see a bimodal distribution of 5 to 7 years old, and then about 10 to 14 years old in puberty. Generally, the incidence in male and females is the same. However, in older onset type 1 diabetes, there's a slight male preponderance of 1.5 to 1. Okay, so this is just to share to you that adult onset type 1 diabetes is actually not as uncommon as you think it is. Actually, 60% of type 1 diabetes are actually adult onset. So in fact, 37% of type 1 diabetes actually starts at the age of above 30 years old. Of course, you can see from the graph, it is skewed towards the left, the age of less than 20 years old. But you got to remember that even though the incidence, as if it goes down lower and lower, what you got to remember is, you can see in the dark, in the line above it, that actually the incidence per 100,000 is actually similar, in the younger age group and the older age group as well. It is just that because of the increasing, incidence and prevalence of type 2 diabetes, that's why it drowns out the type 1 diabetes. Actually, the incidence in younger and older age group is actually the same. Yeah. So the median age to develop type 1 diabetes is actually 24 years old, slightly older for men than in women. So do not forget about type 1 diabetes, even in older adults. So when you talk about type 1 diabetes, there are certain features whereby I can, tell you that, yeah, this is more likely to be type 1 diabetes rather than type 2 diabetes or the others. So there's no pathognomonic feature, I would say. However, a constellation of features, the more you have a checklist of features that they have, it pushes you towards the more likelihood that the patient has type 1 diabetes. So younger age of onset or less than 35 years old is a little bit more to type 1 diabetes. A lower BMI of less than 25. And when you talk about lower BMI, I think it's very important to always ask the patient's weight. What was their weight even prior to the diagnosis? So sometimes the patient comes to you newly diagnosed diabetes, they may be 50 kilos, they're quite lean. But when you ask a little bit more, actually he used to be way heavier. He used to be 70 kilo, has been losing weight gradually. Then that's probably more to type 2 rather than type 1. He was actually overweight. So I'd like to ask about the patient's weight, not only now, but also during diagnosis and before diagnosis, what was his weight like? time to insulin. So if you require insulin all this while, you're probably at type 1 diabetes. And one of the things that I like to use is I like to ask about the patient's compliance to insulin, because some patients tell me, presume to be type 1, but then you find out that actually they're not very compliant. They have missed insulin for many months, then come back again, without DKA. Yeah, unlikely it is type 1. Because type 1 diabetes, if they because of absolute insulin deficiency, if they default insulin, even for a day or two or even a few days, they would have developed DKA already. All right. Unintentional weight loss, presence of ketoacidosis, and very high glucose at presentation are all discriminating features for type 1 diabetes. And some of the weaker discriminators includes family history of autoimmune conditions in the autoimmune condition in the patient herself, ketosis without acidosis, and postmotic symptoms. Okay, just to draw to you, some of the systemic review has placed, age, number 1 means the highest discriminatory value, followed by 2 and 3. So age at diagnosis gives the highest discriminatory value, followed by whether patient is insulin treated, and number 3 would be the BMI. All right. So just to show to you, if you can see on the left-hand side, you look at the area under of curve, yeah. You can see if it's more than 70%, it is a fairly useful test. And you can see a BMI of less than 25 and a young age of diagnosis, as well as also other features such as weight loss, are fairly strong discriminator features. However, if you look down there in the table below, the more features that you have, the area under our curve and sense becomes much higher, the sensitivity and predictive value improves as well. And you can see on the right-hand side from another study, whereby some of the strongest determining value would be actually the time to insulin from diagnosis, as well as also the age of diagnosis, then followed by the patient's BMI. All right. So just now we talk about type 1 diabetes being an autoimmune destruction of the islet cells. So obviously you must measure the islet antibodies. So to give you a brief idea, there are actually many different types of islet antibodies. The first one discovered, as you can see in this immunofluorescence here, actually islet cell antibody, but it is actually not very specific and very cumbersome to measure. Later on, we measure even more specific kind of autoantibodies. And you can see the picture on the right. Actually, these are antibodies that target different apparatus of the islet cells, would be the one that secretes, insulin, and so on, right? So different parts of the islet cells. So, what it is important to remember that the absence of islet cell antibodies do not exclude type 1 diabetes. This is what we label as type 1B diabetes. And it is important to remember 5 to 10% of type 1 diabetes are actually negative for autoantibodies. Why negative? Probably because there are other rarer forms of antibodies that we have not discovered that also this results in destruction of islet cells. So that's why probably 5 to 10% are actually negative. So remember, islet cell antibodies negative does not mean it is not type 1 diabetes. All right. And the second thing I want to note is the presence of low GAD titers does not mean it's type 1 diabetes. As you can see in the picture on the right, in patients with healthy control, even a small proportion might have, a little bit of GAD low titers positive. In other forms of diabetes as well, including type 2, you can have, some of them might have low titers of GAD antibodies, right? However, of course, if you have more antibodies positive, specifically 2 or more positive islet antibodies at high titers, you're probably dealing with a type 1 of LADA. All right, so I'm sure you are all familiar with this form. This is our IMR form, and these are the antibodies that we send: anti-islet cell, anti-GAD, and anti-insulinoma-associated antigen 2. We do not have the zinc transporter antibodies, right? And it's actually not cheap, I remember back in UN, we want to send one individual one, so it's about 250 to 300 ringgit for each. So the panel also can cost the patient quite a lot. So do not simply send like in KKM setting, right? Right, so just a revision on what C-peptide. C-peptide is a proxy marker for endogenous insulin production. So if you have type 1 diabetes whereby you have no endogenous insulin production, you expect C-peptide to be very low. And for the picture on the right-hand side, you can see this whole chunk here is called proinsulin. After being cleaved, the green color will be C-peptide and red color will be insulin. Then some of you might wonder, why don't we just measure insulin? Why want to so troublesome measure the C-peptide, right? It is because it is more better because insulin might come out in a very pulsatile kind of manner. Sometimes you don't really catch it. So C-peptide is more stable, yeah. If patients already on insulin, sometimes we measure the insulin, you might actually end up measuring the exogenous insulin, the ecrapid or whatever you're injecting the patient. So rather than the endogenous insulin production. So that's why we measure C-peptide. All right. So when and how to measure C-peptide? Of course, the best way to do it will be to do formal stimulation tests, for the most accurate and reproducible kind of results. So we actually use glucagon or mixed meal test. But however, in our clinical setting, it's probably not easy to do that. So we'll probably just do a C-peptide without a formal stimulation test. There are some suggestions that non-fasting is actually better than fasting C-peptide. As you can see on the right-hand side, the lower one here will be type 1s, and the one that's higher is actually those with type 2. And you can see the gap when it is being done a non-fasting and random, the gap between type 1 and type 2 is actually quite big. However, you do fasting, you see the gap is even smaller, so probably a little bit hard to differentiate. So I think a lot of us, our setting, we like to do it as a non-fasting sample. Practically, how I do it in my setting is patient comes to my clinic that day, I'll tell the patient, if you have not eaten or jabbed your insulin, why don't you go have breakfast first without insulin? Then subsequently, please go get your C-peptide check. So that in a way, I try to stimulate C-peptide to come out after the patient's meal. And I always want to pair it with RBS, because if the patient, for example, had insulin before and developed hypoglycemia, your C-peptide is low, that is normal, right? But if your RBS is elevated but your C-peptide low, then that is abnormal. All right. And I think one very important thing to remember is do not take the sample during DKA. Why? DKA occurs because of, lack of insulin in the body. Either it may be transient due to glucose toxicity, or it may be permanent, probably like in type 1 diabetes. So the pathophysiology to develop DKA means the patient has no insulin anyway. So when you check the C-peptide, the patient won't have insulin anyway. So it would be low. So it is best to check the C-peptide as an outpatient setting when the patient is well, not when the patient has so much glucose toxicity due to DKA, when the C-peptide will be low anyway, right? Okay, so what kind of cutoff do I use? I think a lot of us use the cutoff was 200 picomole per liter. So a result of less than 200 picomole per liter means the patient has absolute insulin deficiency. Yeah, so mind you, earlier in our case, the patient has two results. One was about 80, another was 180, both for less than 200. So it seems like absolute insulin deficiency, but I believe it's actually low because of the DKA causing glucose toxicity. That's why the result was not reliable. All right. So this is just show you the algorithm, but I just want to focus down there, at the bottom here, what kind of C-peptide values do you use? So when the C-peptide level is more than 600, means the patient has insulin production, then you're probably thinking about MODY and type 2 diabetes. And if it's less than 200, means absolute insulin deficiency, the patient is probably having a type 1 diabetes or LADA, and 200 to 600 is probably an indeterminate level. You may want to report it later on, in a few years, because when the autoantibodies have destroyed more islet cells, the own endogenous insulin fall further, it might be negative later on. All right. So when we talk about antibodies as well as C-peptide, you must talk about also stages of diabetes. Last time stages of type 1 diabetes, we used to say 3 stages of type 1 diabetes, but I think in recent literature, they have actually this labeled as 4 stages of type 1 diabetes. So the first stage of type 1 diabetes will be when patient have presence of 2 or more autoantibodies, but blood sugar is still normal. And type 2, because of some initial damage to the islet cells, right? The islet cells have some dysfunction, but it is still present. So they have dysglycemia. So rather than having overt diabetes, they probably have impaired fasting glucose or impaired glucose tolerance. And then you enter into stage 3. Stage 3 is where the patient has overt diabetes. But nowadays, the stage 3 is divided into another stage 4, whereby established type 1 DM. It is because patients with type 1 diabetes actually have a honeymoon phase, whereby, in stage 3 is probably the honeymoon phase, whereby the islet cells are actually very, very low, but they still have a little bit of reserve. So normally, sometimes in type 1 diabetes, you can realize that maybe in the first 6 months or 1 year of diagnosis, after they came in with DKA, the sugar can improve tremendously and they result hypoglycemia. But later on, they will develop the full-blown type 1 diabetes because the islet cells have still a tiny, tiny bit of remnant because of that. But inevitably, they develop stage 4 diabetes later on. All right. So just to give you some idea, we are not doing it in Malaysia, but in the more resource-rich center, they're actually talking about screening for type 1 diabetes. Why they want to screen is because they want to, a lot of our type 1 diabetes, I'm sure you realize from clinical practice, we diagnose them because they come in with DKA, right? So unlike type 2, whereby the onset is more insidious, type 1 is more sudden. They come acutely or DKA, very ill, has to be admitted, sometimes even ICU. So they want to detect a type 1 diabetes even before they develop DKA. Sometimes, you know, you want to prepare the patient like, oh, chances are they might get type 1 diabetes. They probably want to start the patient education and mentally prepare the patient and the family. And of course, whether we can prevent progression. Yeah. So, you know, on the table on the bottom right, you can see there are actually certain monoclonal antibodies, including this teplizumab, whereby it is given to stage 2 diabetes to try to delay the onset of type 1 diabetes. So we have some data, but you know, it's very expensive, and inevitably, a lot of them still develop over stage 3, stage 4 diabetes lah. So I think it is still more to a research setting, but hopefully one day we'll get to a point whereby we can block these autoantibodies and completely halt the progression of type 1 diabetes. But we are not there yet. Yeah. So yeah, that's all about screening lah. Okay. So that is about type 1 diabetes. So LADA. So LADA is called latent autoimmune diabetes in adults. So you know, this is a very popular Korean shooter. So just to relate back, you know, earlier I showed you another Korean shooter, right? So you another Korean shooter. So it's actually related, but this Korean shooter is actually older, yeah. So that's why it's latent autoimmune diabetes in adults. All right. So sometimes it is called type 1.5 diabetes. Why? Because they say it is share the features of type 1 and type 2 diabetes. So a lot of them starts out without requiring insulin. However, they develop autoantibodies. And these autoantibodies, in place of instead of straight away knocking out the islet cells, they take their time. Yeah. However, after a couple of years or more, they ultimately require insulin. So unfortunately, this is in a way like the tortoise are slow and steady, but they still destroy the islet cells lah. Yeah. So it is actually a chronic autoimmune destruction of islet cell, which is slowly progressive. Yeah. They have a variable prevalence of 2 to 12%. So LADA, what is more important to remember LADA is actually, firstly, they have to be older lah. Yeah. So LADA is often occurring in patients more than 30 years old. All right. So they must have the presence of diabetes autoantibodies and initially do not require insulin, but at least after 6 months later, sooner or later, they still require insulin, right? So these are the broad 3 characteristics of LADA. And just like type 1, they're often lean. They may be family history of autoimmunity, right? Like we mentioned just now, they appear lean. They don't appear like type 2. They appear more to type 1. Yeah. And sometimes it is related to autoimmune conditions such as Crohn's disease and so on, right? But it's just that it occurs in a later age and they don't require insulin immediately, but maybe after 6 months, 1 year, or a little bit more, they still require insulin, but they have autoantibodies. All right. So in terms of the management for LADA, probably not sulfonylurea. Why? Because they say, you know, sulfonylurea, you know, you're trying to squeeze out the insulin from the beta islet cells. So theoretically, you might exhaust the islet cells further. So you probably do not want to use sulfonylurea. But the management of it probably depends on how much residual insulin production the patient have. If the C-peptide or the insulin production is already very low, you're going to treat them like a type 1 diabetes. However, if let's say they're in between, okay lah, maybe can consider a bit of insulin if the other agents doesn't work. And let's say they still have the endogenous insulin production, you're probably going to treat them like a type 2 diabetes. All right. So so this is how you treat. So you screen the antibodies, right? So if it's positive, you measure the C-peptide. So this side the cutoff is a little bit different lah. 3 nanomole per liter is our 200 picomole per liter. So instead of using 200 and 600, they use 300 and 700. So about there, like, is this a spectrum? So it's about there. So if let's say they have no insulin, it is less than 0.3 nanomole per liter, or now we talk about 200 picomole per liter, it's like a type 1 diabetes already. So you need to treat them with basal bolus insulin, no other way. However, You know, just now we saw more than 600 picomole per liter patients still have insulin. That's more to type 2, right? So if they still have so much insulin, you probably want to treat them like type 2 diabetes rather than treating like type 1 diabetes. And of course, if it's in between, you probably will treat them in between with some insulin and maybe some oral agents. All right. So how you treat them is on the left hand spectrum is like treating like type 1, right hand spectrum treating like type 2. Lor. That is why you know, LADA is sometimes called type 1.5 diabetes. Yeah. Okay, so in terms of treatment, you know, less than 0.3, we say insulin. But if let's say it's indeterminate 0.3 to 0.7, again, no sulfonylurea. And then treatment choices when I choose, really, it's just like our type 2 diabetes. ASCVD predominate, GLP-1RA, SGLT2. Heart failure, CKD predominate, SGLT2. And if it's not to target, then we add in you know, insulin for the patient, probably a basal first, maybe not control, a bolus. But what you got to remember for these patients will be the SGLT2, because we do expect the C-peptide, which means the insulin to decline with time, and you do not want to keep SGLT2 you know, in somebody who has no endogenous insulin due to the risk of euglycemic decay, right? So this is when the patient, let's say, you know, yeah, we mentioned already lah. Yeah, so it's like treating a type 2, you know, diabetes, start those agents, but just be very careful, you know, a little bit regarding the SGLT2. All right. So the next one, I talk about maturity onset diabetes of the young. So if you remember this shooter from the Olympics, you know, he looks a little bit old, so more mature. But the reason why I put him as the, you know, figurine for our MODY is because you can see, right, he don't need any gadgets, you know, don't have any ear muffs, don't have, you know, special eye equipment. So it's kind of like MODY lah, you know, most of our MODY actually, you just need a little bit of treatment. You don't need a lot of hi-fi insulin or technology. So that's why I use him to represent our MODY lah. Okay. So MODY, sometimes it is called monogenic diabetes. It is autosomal dominant. Due to one gene defect, passed on autosomal dominantly, you know, the family all also develop diabetes. So that's why there's a very strong family history of diabetes. You know, traditionally we say the 3 generations of diabetes lah, but that may not necessarily, you know, be a must, because sometimes the patient who has MODY, maybe he's the first person to develop MODY in his family line, kan? So not necessarily, yeah. So it accounts for 4% of diabetes in those less than 30 years old. So in the traditional triad of MODY, we say patients less than 25 years old, autosomal dominant, and the lack of diabetic antibodies. So their main features are they often are young, less than 30 years old, because you know, it is an autosomal dominant thing. We do expect at least one first degree relative to have diabetes. Yeah, but of course, sometimes unfortunately the patient himself is the first person, so no family history. Clinical features does not compatible with type 1 and type 2, negative antibodies, and they have residual pancreatic function, means they have C-peptide. Okay, so this is how you suspect it. So you suspect a patient have MODY, you know, you send the because of the features of hyperglycemia, less than 30 years old, not fitting type 1 or type 2, and family history of diabetes is very, very strong, especially if 3 generations. Then you look at whether it's the insidious onset or acute onset. If it's more the acute onset, you know, especially if antibodies are positive and no C-peptide, okay, you know it's type 1. But it's a little more insidious, then your antibodies are negative, still got C-peptide, then it is in between type 1 and type 2 and MODY. And then type 2, probably you would choose type 2 if the patient has more metabolic features, a little bit, you know, higher BMI, features of insulin resistance, such as acanthosis, yeah. And MODY, probably if they're a little bit leaner, or family history of diabetes is very, very strong. Okay, so for those who like to look at numbers and calculators, there's actually a MODY calculator if you're interested by Exeter. So you just key in MODY calculator by Exeter Diabetes. So they ask for certain features the age of diagnosis. So younger age favors MODY, the sex, current treatment, time to insulin. So you know the chances that you do not require insulin, you're more MODY. Yeah, BMI, leaner BMI, HbA1c, you know, not too high, not too low, a little bit lower. Current age, parents, ethnicity, strong family history, you know, point you towards more MODY lah. Then you'll come out with a result or what is your chance of this patient having a MODY lah. Yeah. Okay. So So in terms of MODY, previously, they used to label it the 6 different types of MODY, MODY 1, 2, 3, 4, 5, and 6. However, the more we understand about MODY, you realize that it's actually not so simple. There are so many mutations involved. So there are at least 14 well-described MODY in the literature, but there can actually be more genes. There are more MODYs that have not been very well described. Okay. So what happens is, the genetic defect occurs in different parts of the islet cells. So like HNF1 alpha, HNF1 alpha, IPF1, HNF1 beta, it affects the transcriptional regulation, at the nucleus there. Sometimes there's an enzyme disorder, the glucokinase, that's why you develop GCK MODY, and so on. Sometimes the ion channel disorder occurs and results in MODY. So different parts affect, different genes affect different parts of the islet cells and develop different type of MODY. All right. So one of the types of MODY, which is, you're going to choose any type of MODY, you probably want this MODY. It will be MODY 2. So glucokinase, so GCK. It is just that the patient has higher threshold of glucose-stimulated insulin. So it means that, for example, normal humans, my insulin will come out at a glucose of, let's say, 5. But these patients, the insulin only come out at higher level, let's say 7. Right? So it's just to show to you, like, for example, you can see on the graph on the right. So on the lowermost would be how our glucose level would be after, before and after meal. There's a little spike, small little spike after breakfast, lunch, and dinner. For GCK MODY, you can see, right? Okay, the fasting is a little bit higher, right? It spikes up after every meal, but the spikes, the degree of spike is actually probably just like the normal patients, just spike a little bit and go back down. So basically, it's just like shifting the baseline a little bit higher. So unlike type 2 diabetes, whereby the fasting is this high, and every time you eat, the fluctuation of glucose postprandially is even higher. All right. So this patient actually have a stable mild hyperglycemia. So the FBS and HbA1c may be mildly elevated, but their postprandial excursion is actually not very high. It's just like a normal person. You just go up maybe about 2 millimoles, 1.5, 2 millimoles. They don't go up too extreme. And most importantly, it is not progressive. So it is not associated with any diabetes vascular complications. So the treatments, actually, you don't need any medication, just diet control. Yeah, don't need to worry about it. All right. So remember, the feature again is a stable mild hyperglycemia. FBS and HbA1c might be elevated, but postprandial excursion is not crazily high like other form of MODY or even type 2 diabetes. Okay, the degree of excursion is as per what you would expect like a normal person. All right. Just in case you are interested in, just mention a little bit, if in pregnancy, how you're going to deal with GCK or this MODY 2 will be, depends whether the fetus inherits the GCK mutation or not. So if the baby also inherits the GCK mutation, no intervention, because the baby's own threshold for, insulin and glucose is the same. However, if the baby does not have the GCK mutation, then the maternal higher glucose level, which is okay for the mother, may be detrimental to the baby, resulting in macrosomia. So how do you want to know whether the baby have inherited this GCK or not? If you really want to know, you'll be invasive sampling, but not worth it lah. I want to do corneal veni sampling just for this. So some people suggest that we will just do a serial ultrasound as often as 2 weekly after 26 weeks. So, when hyperglycemia, the one that's going to grow would be actually the abdominal circumference. So if you see, the abdominal circumference go bigger and bigger and bigger, 75 percentile already exceed, maybe the baby is not exposed to this, hyperglycemia. So the baby probably, it does not have the GCK mutation because it is growing much more than you expected. Then you will probably want to consider insulin. All right. So in the future, of course, if technology is available, I'm sure you know what's NIPT. So far, NIPT, the non-invasive prenatal testing, you take the mother's blood to detect the fetal fragment and test it for mutations. We have not reached there yet. We do it for our chromosomal abnormalities, but we have not reached the level we can detect GCK mutation. But this will probably be something to look forward to in the future. All right. Let's talk about the other two MODY, MODY 1 and MODY 3. So HNF4A and 1A. So in these two type of MODY, there's a defect in insulin secretion. So in order to make it secrete insulin, you give medication that will force the insulin to come out. So that will be sulfonylureas. Okay. But the thing is, this secretory defect may progress with time. So as time goes on, they may require insulin many years into their disease. And when this occurs, they are also liable to the vascular complications of hyperglycemia lah. And unlike GCK, you need to treat the patient because the patient can develop vascular complications, the babies can develop the complications of hyperglycemia. So, you need insulin during pregnancy. Okay, so for those who like, to know a little bit more, the HNF1A have lower threshold for renal threshold for glucose, so they have glycosuria. They also, have lower hsCRP and high HDL. So if you don't have genetic testing, easily available, or you want to do this first, genetic testing, you can actually do this, look for all these features to differentiate between HNF1A versus HNF4A lah. All right. So you see on the graph on the right-hand side, the third one, which is HNF1A, the hsCRP is a little bit lower lah. Why this occurs? They say because this gene also has a role in the CRP, so defective, so the CRP also is a little bit lower. And why HDL, something to do with the hepatic lipase activity lah. So there's also the defect, so they cannot break down the HDL, so HDL appears elevated. And just for those who are interested, think, oh, okay lah, good, right? Got high HDL means very cardioprotective, right? Unfortunately not lah. There are studies that show that this high HDL does not protect them from cardiovascular issues. Okay, then this is the slightly more scary form of MODY, modified HNF1B. So it is characterized by the presence of sites for pancreatic atrophy, will be the renal. They have a lot of renal dysplasia or cysts, and this can develop and progress to sometimes even end-stage renal failure. Yeah, so remember, HNF1 beta has a lot of kidney issues as well. Yeah, some other features including hypomagnesemia. I do not do this, but in those people who are interested in scoring systems, you can see on the right, there's actually a HNF1B scoring system. A score of 8 and more, suggests the patient has what they call that, this MODY 5 lah, right? Okay, so so this is how clinically, if you want to diagnose and differentiate the different type of MODY. All right, so I think the top one we already went through already. We look at the onset, the presence of C-pattern autoimmunity. We already differentiate between, the type 2 DM and type 1 DM. Okay, so if you suspect MODY, then you want to see what kind of MODY that the patient had. So for example, if patient on the left-hand side, you can see the fasting glucose is just mildly elevated. HbA1c also not too high lah, 7.5%, 8%, or a little bit lower. Then when you do OGTT also, the rise of postprandial glucose, is not that high. For example, FBS of 7, postprandial 9. Okay, don't jump too high, ma. Then you might be dealing with GCK MODY. All right. If you have, like we said, all those renal issues that we mentioned, a lot of renal cysts, progressive renal deterioration. Then you're talking about HNF1B. All right. Okay. If not, then you talk, if you have progressive glucose, but then if responds very well to sulfonylurea, then you're probably talking about HNF4A or 1A MODY. And how you differentiate it, as like what we discussed earlier, in HNF1A MODY, you have presence of glycosuria, HDL is high, and low hsCRP versus HNF4A. However, talking about all these features, if you really cannot, just send the genetic testing. Yeah, then you tell you everything I did. Don't need to do any guesswork. So where to do genetic testing, they can send to different places. So I think in our endocrine fraternity, we sometimes try to discuss with outside labs, like Exeter or Chinese University of Hong Kong. Prof. Lim has connections over there. But one of the places that I often send is Invite. Invite is because Putrajaya, we had created links with Invite Lab. So we do send samples to there if our patients are willing to pay. What's the cost? If I remember correctly, maybe you need to prepare slightly below 2,000 ringgit, about maybe 1,600, I think, for the panel. 200-300 ringgit to send the FedEx overseas. Yeah. So just now we talk about 14 different types of MODY. They actually check about 28 gene panel for different types of MODYs. Yeah. So they check many different types. Okay. So talking about type 1 diabetes, MODY, and LADA. So I think let's go to the more clinical and practical thing. How do we approach a young diabetes? All right. So again, of course, the definition of young is very heterogeneous. We know that. So this is what I routinely look for when I see a patient who is fairly young, maybe like meaning they are youth or young adults, less than 30 years old. I'd like to know what's their current age and at what age they develop diabetes. Obviously, you develop diabetes at the age of below 10, you're talking about type 1, you're not talking about other things. But the slightly you're older, then the likelihood of probably type 1 DM and LADA become a bit lower. You're more than type 2, but not necessarily. Age is a determining factor. Like you look at the whole package. Family history, yeah. So family history for type 1 diabetes is not as strong compared to perhaps MODY. You got 3 generations of diabetes. I want to worry about diabetes a little bit, MODY a little bit more. I want to look whether the patient has metabolic syndrome, not only at the weight and the weight at the diagnosis, their current weight, but their heaviest body weight. Any other features of metabolic syndrome, such as blood pressure is high, dyslipidemia, acanthosis. So this will push you towards a type 2 diabetes. However, if you do not have all these, they are a bit more lean, then maybe you're dealing with MODY or type 1 diabetes. I'd like to know a little bit on the diabetes history. How's the presentation and onset like? Type 1 diabetes tend to be very acute. Yeah, the other forms of diabetes probably a little bit more insidious. They came in with, came in with DKA or HHS? The fact that you come in with DKA acutely, I'll consider more of type 1 or maybe a bit LADA rather than type 2. But not to say don't. I mean, type 2 can come in with DKA also, but probably they have more protracted symptoms compared to type 1 diabetes. I don't know what kind of medication that they have that they're on at time to insulin. And like what I said earlier, I like to ask about patients compliant to insulin. So I got a lot of patients who are diagnosed with type 1, but then when I ask them and say, oh, you're not compliant to insulin, I've been insulin for a few months before, I never had DKA. You're probably not dealing with type 1 diabetes. They can't default insulin and don't get DKA. That's very, very odd. Yeah, at least for a long period of time. Okay, then presence of autoimmune condition can push you towards a LADA and type 1 diabetes, and of course, clinically look for BMI and acanthosis like glucose. Okay, so investigations, the 2 things that we talk about, we send diabetic antibodies and we send a C-peptide. I often send it, soon after their resolution decay, I'll send it if it's their first presentation. You can reassess 3 years later on because with the progressive destruction of islet cells due to antibodies, sometimes the C-peptide does fall that you might want to revise your diagnosis. Yeah. So I often send it non-fasting. Usually I ask them to have a meal first, and I'd like to pair with the RBS just in case the patient has hypoglycemia and make it a falsely low C-peptide. In a sense. And then, of course, you suspect MODY. If it's available to you, you can send for genetic testing for MODY. Okay, so this is what we discussed about. This is the algorithm. All right, so let's move back to our case. So just a reminder, this is a young lady, 17 years old. She was diagnosed with diabetes since 12 years old, 3rd admission for DKA, and she's on insulin. So upon discharge, obviously we get her on basal bolus insulin, not only because we assume she's a type 1B diabetes, but also because anybody with DKA means that they're insulin deficient at that moment. You probably want some insulin on board. However, once the glucose toxicity resolves, the islet cells has recovered, they probably can wean off their insulin. So regardless, no matter what type of diabetes she came with DKA, I would still discharge her with insulin anyway. So apparently the father said that she's more compliant to her diet now. The dad supervises her, check her glucose and realized that actually, she has actually recurrent hypoglycemia at home at different time. And because of that, she was very worried. She even stopped insulin on her own, for a few days before she came to TCA. And we look at the SMBG, quite well controlled, actually 5 to 7 millimole per liter. So this time, I looked at the 2 C-peptide, I felt they were not truly reflective of islet cells. So that's why function. That's why I sent the C-peptide again in the clinic. I asked her to have breakfast and then check her C-peptide with RBS of 14.5. Oh, C-peptide is actually quite good, almost 600 picomoles per liter. So it means that the patient actually has endogenous insulin. And I guess we're not talking about LADA over here because she's 17 years old. And type 1 diabetes, I don't think she's honeymoon because you diagnosed her in 2019. So 2024 means 5 years, or you don't usually honeymoon for so long. So that's very odd, right? So it doesn't fit into type 1 diabetes anymore. And the A1C, low and behold, 5.9%. So I'm a coward lah. So I dare not off all the insulin. I tried changing to Levemir first. So I start a little bit of Levemir. She still developed hypoglycemia and still not very compliant because of hypoglycemia. She check at home, actually the sugar quite well controlled, 5 to 9 millimole. So okay lah, I offer insulin. I changed it to oral agent. And I said I'm a coward lah. So I probably can just give metformin, but I just get the sugar went up very high. So I throw in beta-glutin, something that won't cause her hypoglycemia. But in case the sugar go up high, she's due for reassessment soon lah. So so at the end of the day, I actually diagnosed her with young type 2 diabetes instead of type 1B diabetes. And I do not think it's MODY. Unless slightly MODY is because although her paternal and maternal grandparents have diabetes, actually her parents and siblings have diabetes. So that's a little bit odd lah. MODY, you do expect, you know, first degree relatives to have diabetes. So that's why I did not consider MODY for her. All right. So if you're the one who like to look at algorithm and charts, this is the one by the ADA and EASD. So so for our patients, the islet cell antibodies are negative. All right, she's less than 35 years old. Okay. I do not think it's monogenic diabetes because the family history is not consistent. And then the features of type 2 diabetes, I thought, yeah, maybe because she was a little bit overweight last time, right? So that's why I went up here. And because of that, I reassessed her C-peptide. It looks like her C-peptide was 600 lah, so about there lah. So I revised her diagnosis of type 2 diabetes. All right. So in summary, correct classification of diabetes in young adults can be challenging. Misclassification is common. So how you approach it, you want to go through the clinical features of, you know, different features that the patient have. You know, type 1 discriminatory with the age of onset, time to insulin, the BMI. LADA is more than 30 years old, is more slowly progressive. They require insulin not immediately, but later on. Yeah, MODY really depends on what type of gene that the patient has defect. Send for diabetes autoantibodies if you suspect or you are unsure. And you send for C-peptide lah. I often send non-fasting and RBS. Less than 200 means the patient does not have any C-peptide. Okay. So, all right. Thank you so much. I am very happy to accept any questions. All right. Thank you.
Right. Thanks very much, Ken Singh. That was beautifully presented. There were separate big topics, but they were both very concisely presented and with very precise ways of getting around it. Thanks. There's actually just one question in the box here, but I've got a couple of queries maybe after that.
Okay.
It says, do we test for all the autoantibodies for suspected type 1 diabetes, and which would be the more common ones to be positive?
So if you suspect a patient to have type 1 diabetes, so you're unsure of it, you should send for diabetes auto antibodies. In our KKM setting, I assume most of us are from KKM setting. So it's actually in a panel. We don't usually send individually. However, if let's say you have, you know, patient has financial constraints, for example, you're doing it outside or patient, you know, like back in UM, they have to pay their own. If you really have to choose one, GAD, send GAD. Then you can send the others if you want. Yeah.
Okay. Yeah, thanks.
If it's
I think
negative,
the
then you
IMI
send for the others lah.
panel does,
If it's positive, then
yeah.
stop lah.
The IMI panel, I think, does 4 of the 5 we have. We don't do tyrosine phosphatase here, if I'm not, sorry, the zinc phosphatase here.
Zinc.
Yeah. So we still, yeah. All right.
So
yeah, if I could just ask, there's been some schools of thought that if your A1C, HbA1c is very high, even outside of DKA, that itself could potentially suppress the C-peptide. And, you know, so is there like a cutoff if patients come in for regular clinic reviews? We do have patients with A1Cs of 12, 13, you know, and if you send a C-peptide at that time, is it going to give you a false low, or are we happy to go by those results?
So I guess I will just go back to the patient's symptoms, I guess. If the patient has symptoms that suggest insulin deficiency, for example, have polyuria, polydipsia, very significant weight loss, then probably your worry by the patient can be insulin deficient, you know, and probably can be falsely low because of that. But A1C is not controlled, and, you know, patient does not have those features to suggest that they're really insulin deficient, then I'll probably still send a C-peptide and see how it goes lah.
Yeah, fair enough. I suppose if it's high, we are happy to believe it. If it's low, then, you know,
yes,
you might
it's
want
low.
to take the clinical picture. And
Yes.
yeah.
Yes.
Yeah, I just... So yes, you didn't mention low GAD titers. Is there any cutoff number to go by, or is it just like a spectrum or a general thing?
I do not have any figures for you, but I remember I did send some young diabetes before. Actually very low one, like just 2 or 3 times upper limit. You know that our type 1 is super duper high one, right? We normally see.
Yeah,
So I do not have a title for you, but
there's
I
no
believe it's a
cutoff. Sure,
spectrum.
sure.
Yes, yes.
All right. Yeah, there's another question in the box from the same person. If a type 1 diabetes patient is unable to commit to basal bolus insulin 4 times a day, having regular meals, can we give mixed type? Yes.
So I think at the end of the day, it boils down to the patient's lifestyle, as well as also lifestyle meaning what are they going to eat, and are they able to cope with the insulin? If the patient tells me they have fairly regular meals of the same amount, I think it is fair you want to give a co-formulation kind of insulin or premixed rapid acting kind of, analog kind of insulin. It is possible, but to be very honest with you, I find it very not flexible. Why? It's because, they are so sensitive, right? So they just eat a little bit more, the sugars also can go up. So by right, if you ask me, you probably want to teach the patient how to do their own carbohydrate counting. When they can eat a little bit more, they can adjust the insulin a little bit more. But so I think that would be a better way to do it. But of course, like you say, if changing analog insulin also they cannot cope, then I guess you can also do it lah, but it won't be very flexible lah. Yeah.
Yeah, thanks. I think this is quite a common, it's not an uncommon scenario rather, because you've got young patients, they're not willing to inject 4 times a day, but they're eating 3 good meals and they're eating erratically, and they want to do mixed start. So it's not ideal, but again, life gets in the way. So, I suppose we choose the best regime that we can tailor for the patient and us.
Yeah.
Yeah, I think we don't have any more questions there. And yeah. So thanks very much, Ken Seng, for the very insightful talk, and I hope everybody benefits from this. If there are no more questions, then we may close the session.
Dr. Gayatri, I
Thank
think
you.
there's few questions in the Q&A box.
Oh, I'm sorry. I can only see these 2 questions in the box which I've mentioned. Are there more that I've missed?
There's about 6 questions in the Q&A box.
Oh dear.
Yeah, there's another
there's
box.
another.
The Q&A.
Okay. I'm sorry. Okay. Sorry.
The first question is
then-
what
yeah.
autoantibodies can we send from KK?
Sure.
I'm not sure you all can send. I'm not sure whether you can send antibodies or not. I'm not sure. But of course, in our hospital setting, our general medicine physician also can send. We are the one who send that to the IMR. But KK, I'm not sure. Do they send that, Gayatri? I don't think so. Right? I know
I
they send
think
C-peptide.
the IMR, if I'm not wrong, the
Yes,
IMR
sir.
form needs the signature of an endocrinologist. So I think it
I
has
see.
to go
I
to
see.
a hospital with an
To us.
endocrinologist. Yeah.
Okay, thank you.
Yep. Someone had said there that FMS signature can also send. Yeah. So if you've got an FMS,
Yes,
you can
yes.
sign off. Yeah. Then someone has answered that it's another endocrinologist. Yeah. A few people have helped out there. Yeah. The next question
Thank
is,
you,
hi,
thank you.
doctor. Is young onset diabetes the same as youth
Ah.
onset diabetes?
A slightly different age group. Youth one, you're talking about teenagers, so you're talking about those less than 20 years old. Young onset, slightly variable, but generally less than 35 years old. So youth are actually younger than the young onset. Yeah.
The next question is, when do we start sulfonylureas in MODY? Any difference between the different types? I thought you said do not start sulfonylureas in MODY though.
That will be the LADA, I think. Yeah. But so
Sorry.
sulfonyl, yeah. So I guess it will really depends on what kind of MODY do you think it is. If you suspect it's a GCK, by virtue the postprandial glucose is not high, just mild hyperglycemia, I wouldn't start anything aside from just diet. However, if you think it's those, HNF1A and also 4A, then yes, you can start sulfonylurea. I think the trickiest part to start it is a lot of times, they are presumed to be like type 1 or something. They're on basal bolus insulin. I think the scary part is always to de-escalate therapy and change to sulfonylurea. To me, that's the scary part lah. You're scared it might decay, but I guess you just do it gradually lah. Slowly cut down and slowly introduce the sulfonylurea until you can off the insulin and get the
Yeah, sure.
sulfonylurea.
Sorry, I got the MODY and LADA a bit mixed up.
Yeah.
The next question is, Doctor, can you explain why the honeymoon period happens in type 1 diabetes?
That is because, I don't have a specific numbers for you, but like for example, in type 2 diabetes, when you're newly diagnosed, you can try OHA first because the patient have some residual beta, islet cells functioning. So the own endogenous insulin can cope with the hyperglycemia with some help from OHA. However, with time go on, you have less and less islet cell mass, you lose about maybe 60-70%, you require a little bit more insulin. Then after that, subsequently, you start losing everything, then you require basal bolus insulin. So imagine an accelerated form, of progression. So in type 1 diabetes, you just bang, you hit so hard, you're supposed to lose everything. However, in that very initial phase, you might have some residual function, just a little bit of beta islet cell left. Especially when you resolve the DKA, this little bit of cells might just recover temporarily before the islet comes and finish them off completely. So they might honeymoon during that period.
Yeah, nicely explained.
Mhm.
Okay, next question is, can we do carb counting in type 2 diabetes?
Yeah, sure, you can do that. Not a problem.
Next question. You mentioned diabetes antibody is negative in 5 to 10% of type 1 diabetics, but aren't there studies to say among Asians, less than 60% are positive?
I'm not familiar with that study, but are you familiar, Gayatri? I'm not
Yeah,
so
no, I'm
familiar.
afraid I
You sure?
don't have that
I'm not,
information
yeah.
at hand either. Yeah, sorry, we'll have to look
Sorry.
into that. Yeah.
Yeah.
Next, can I send C-peptide instead of antibodies? Hang on. Can I send
Ah,
C-peptide instead of antibodies in newly diagnosed diabetes if the patient is stable, like incidental diagnosis of DM through medical screening?
I mean, yes, of course you can do that, but the thing is, you probably want to look whether do you think it's type 1 or not. The reason being, if you realize, right, type 1 tend to come very acutely. They tend to come with DKA and very, very severe hyperglycemia, when they come in. But if they present to you very insidiously, like, oh, just slightly mild hyperglycemia or detected during health screening, not too symptomatic, or then you realize it's probably not type 1, it's probably type 2 or MODY. But yes, you can see peptide, but just bear in mind that if patient might still be, honeymooning or maybe between stage 2, stage 3 of type 1 diabetes. So they still might have some residual C-peptide, so they might mislead you. But antibodies being positive, that's the one that will tell you whether it is a type 1 diabetes.
Yeah, sure. I suppose if money is no object, you can send antibodies for everybody, even to have research. But with the number of
Not your
diabetics
monitor,
in our country, in government setting, we really, really can't afford to do that. Yeah.
Agree.
Yeah, next question, where do we send C-peptide? I think we've already answered that to IMR. FMS can sign in hospitals, endocrinologists or physicians. Yeah, and we've also done the other one where the young onset is the same as youth onset. Yeah, I think that's pretty much all the questions we had. Yeah. I think this time we are really done. Sorry about that earlier. Yeah. So thank you, Ken Singh, very much for all the questions, for the
Thank
insightful
you.
lecture. And I think we can wrap this up.
Yeah. Thank you, Dr. Gayatri and Dr. Chu, for the insightful talk. We'll see next week for another new endocrinology topic. Thank you.
Thank you.